Good morning, everyone, and thank you and welcome to another Excel Healthcare Institute NCLEX review. My name is Alexandra, and it is a blessing and a pleasure to have you here. Let's go ahead and open up with the word of prayer. Our dear Heavenly Father, Lord, thank you so much for waking us up today, and thank you so much for my students. Please help them to understand the important things they need so they can pass the NCLEX the next time they go. I pray they all get their nursing license. Please bless every area of their life. In Jesus' name, amen. All right, guys, we are on page 122 of the study guide. And so we're going to be finishing up adult neuro today. So this green table here is very important for you to study for homework. It talks about how do you take care of a patient who is unconscious. So remember, we're an adult neuro, and many times when you're taking care of a neurological patient, they might have a altered level of consciousness, and they could be unconscious. So make sure you understand that your number one priority when taking care of an unconscious patient is to protect their airway. So remember, if you or I were eating something and we started, and have you ever been eating something and it went down the wrong pipe? Like instead of going down your esophagus, it went into your trachea. What would you do? When food goes down the wrong pipe or water goes down the wrong pipe, what do you usually do? Do you cough a lot? Absolutely. So when you're eating something or drinking something, it goes down the wrong pipe. You usually cough a lot. You have like a gag reflex where you go, right? And that's your body's way of protecting your airway. So write that down. Your gag reflex is your body's way of protecting your airway. And there's other mechanisms your body has in place to protect you from aspiration. Okay, so your body wants to protect your airway because that is how you get oxygen in, and your airway naturally does not want anything to block it. So that's why we cough and we gag. However, someone who is unconscious, they don't have a gag reflex. They may not have the cough reflex. So someone who is unconscious cannot protect their airway. So someone who is unconscious is at high risk for aspiration. They are also at risk for blocking their airway. So that is why protecting the patient's airway is our number one priority when they are unconscious. So we can do that by the position we place them in. We don't want to lay them flat. We want to put them semi-fowlers or higher so that we can promote proper ventilation. And also we want to put them semi-fowlers so that gravity would cause things to go down instead of staying stuck in the airway. Okay? So make sure you read this green table for homework. Next up on page 123, we're going to learn about intracranial pressure, also called ICP. Intracranial pressure is the pressure exerted by fluids such as cerebrospinal fluid inside the skull and on the brain tissue. So anywhere there is fluid, there is pressure. Anywhere there is fluid, there is pressure. And when we're talking about pressure inside the skull, that cerebrospinal fluid exerts a pressure and it presses on the brain tissue. ICP is measured in millimeters of mercury at rest, and it is normally 7 to 15 millimeters of mercury for a supine adult. So remember, supine means when someone is laying flat. So in a normal adult, A normal intracranial pressure when an adult is laying flat is 7 to 15. So please make sure you memorize that. So now we're going to learn about what happens when we have increased intracranial pressure. Increased intracranial pressure can lead to death. Make sure you understand that. So I want you to study page 124 to understand why increased intracranial pressure can lead to death. So when there is some type of injury to the brain or the head, we call that a cranial insult. Okay? So whenever there is trauma to any part of the body, it is your body's natural response to respond with swelling. Some people call it inflammation. So inflammation is the body's natural response to injury. So when we have some type of injury to the skull or the head, we call that a cranial insult. The body naturally responds with inflammation, which is going to lead to a swelling of the tissues, which is called edema. Okay? This increase in the tissues, this tissue edema, it naturally increases intracranial pressure. It's naturally going to increase the amount of fluid inside the skull. And remember, wherever there's fluid, there is a pressure. And so tissue edema increases intracranial pressure. Does that make sense to everyone? All right, perfect. So remember, we said that intracranial pressure, it compresses down on the brain naturally. But when it's normal, when intracranial pressure is normal, there's no damage or risk of damage to the brain. However, when we have the increased intracranial pressure, it increases how much pressure compresses the brain. So that's going to press down on the blood vessels of the brain. This compression of blood vessels is going to decrease cerebral blood flow. It's going to decrease how much blood flow the brain tissue gets. So this is going to decrease the oxygen level that the brain cells receive, which then, if it's severe enough, can lead to brain cell death. That brain cell death is going to lead to more swelling. That's going to increase the intracranial pressure even more, okay? And this is going to press, remember, on the medulla oblongata and the pons, this is going to compress that respiratory center of the brain. Now, we learned in ABGs that CO2 is a what? Is CO2 an acid or a base? CO2 is an acid. So let's go backwards a little bit. So the increased intracranial pressure is going to compress on the blood vessels of the brain. It's going to reduce how much blood flow the brain tissue gets. This is going to lead to decreased oxygen in the brain cells, which, if severe enough, it can lead to brain cell death. Wherever there's death of tissue, there's naturally going to be more inflammation and swelling. It's your body's natural response. So that increase in tissue swelling is going to increase ICP even more, which in turn is going to compress the respiratory system. Because remember, wherever there's fluid, there is pressure. So that increased pressure is going to press down on the respiratory center of the brain, okay? And it can lead to decreased respirations. Didn't we say that hypoventilation will cause CO2 to stay inside the body? And CO2 is a vasodilator, okay? CO2 is a vasodilator. CO2 is going to open up the blood vessels of the brain. That's going to increase ICP even more. Because when you increase the size of the blood vessels, you increase how much blood flow is received. So this increased blood flow is going to lead to more increased ICP. This is going to further compress the brain tissue. It's going to further reduce how much blood flow the brain tissue is getting, and eventually it's going to lead to brain herniation and death, okay, of the brain. So it's very important for you to study that on page 124 and understand why increased ICP can lead to death. Okay, so now back to page 123. And hang on, let me see something here. Let me just switch screens so that I think it'll be a little easier. Okay, so we're on page 123. Okay, so increased intracranial pressure. Some causes trauma, hemorrhage, growths, tumors, hydrocephalus, edema in the brain, and inflammation. So the effect of it is that it impedes or it reduces or blocks proper cerebral brain flow. So the brain tissue cannot get adequate oxygen because this pressure, which is now increased, is pressing down on the brain tissue and it's compressing the cerebral arteries. So assessment of somebody with increased intracranial pressure. So altered level of consciousness. So they're probably not going to be like me and you speaking normally. Okay, they might have an alteration in their level of consciousness. They might have a decreased level of consciousness over time. Headache, vomiting. So vomiting is the body's way of trying to reduce that intracranial pressure in the body. Pupil changes. So the worse the intracranial pressure gets, the more it's going to press down on the brain, and it can press down on the cranial nerves, and it can lead to one of the pupils or both of the pupils dilating. And then we're going to have the vital signs, okay? So the vital signs. Can somebody tell me what are the vital signs of shock? If we were you to use very good, if we were to use arrows, very good. So high heart rate, low blood pressure, high respiratory rate. Right? These are the vital signs of shock that you should have memorized at this point. Remember, you have to know this if you want to pass the NCLEX. So guess what? The vital signs of increased ICP, some people call it IICP, increased ICP, are the exact opposite. So, shock, the heart rate is high. Increased ICP, the heart rate is low. Shock, the blood pressure is low. Increased ICP is high. And then shock, the respiratory rate is high. In increased ICP, it's low. So, two vital sign trends or patterns that I would make sure I memorized for the NCLEX are the vital signs of shock. And then once you know the vital signs of shock, the vital signs of increased ICP are the exact opposite. So make sure you write this down and memorize that the vital signs of shock, high heart rate, low blood pressure, high respiratory rate, and then the vital signs of increased ICP are the exact opposite. And the vital signs of increased ICP are what we call Cushing's triad. So I'll give you a moment to write that down and then we'll continue. And please, I see someone's trying to draw on the screen. If you could just not do that so that everyone can see it, what the screen well, please. All right, guys, so let's go back to the study guide. One moment. All right, so in the book, there is an error on page 123, so that's why I wanted you to write it. So for Cushing's triad, it's supposed to say high blood pressure, low heart rate, and low respiratory rate. Okay, so that's why I had you write it on the other screen. So just remember, Cushing's triad, the vital signs of increased ICP are the opposite of shock, and it should be high blood pressure, low respiratory rate, low heart rate. Okay? So interventions. So when you're taking care of a patient with increased ICP, you want to monitor the respiratory rate and prevent hypoxia. Why? Because what type of respiratory rate will a patient with increased ICP have? A low one. Thank you guys so much. I love when you participate because it helps me to see that you're understanding the material. So very good. Um, and then one favor I ask, can everyone just change the name of their device to their name? Because some of you are on as iPad and iPhone. If you could just change your name so I know who you are. Let's see. Okay, so we were saying that why do we need to monitor respiratory rate for someone with increased ICP? Well, we just said that The respiratory rate for someone with increased ICP, is it going to be low or high?
Low.
Low. Very, very good. So, if the respiratory rate is low, are they going to be bringing in a lot of oxygen?
No.
No, right? If the respiratory rate is low, are they going to be breathing out enough CO2?
No.
No, right? So if they're not breathing enough and they already are at risk for low respiratory rate, they won't bring enough oxygen in, which will cause hypoxia. And didn't we say one of the problems with increased intracranial pressure was reduced blood flow to the brain because the brain tissue won't get enough oxygen. So we need to bring oxygen in so the brain tissue can get proper oxygen. Also, we need to breathe out enough CO2, correct? Because CO2 is a vasodilator. If they keep too much CO2 inside their body, the blood vessels of their brain are going to vasodilate and open and bring more blood flow, and that's going to increase the intracranial pressure, correct?
Yes.
So, when the respiratory rate is too low, CO2 stays inside the body. CO2 is a vasodilator, and that will make the increased intracranial pressure worse. That will increase how much fluid gets to the brain and make the problem worse. So we want to monitor their respiratory rate and make sure it stays, between 12 and 20 or whatever the healthcare provider has ordered. Sometimes they prefer for you to hyperventilate the patient, and we'll talk about that. So, monitor respiratory rate and prevent hypoxia. We don't give morphine sulfate to patients with increased intracranial pressure because morphine sulfate is a narcotic. Narcotics cause respiratory depression. Respiratory depression would cause CO2 to stay in the body. CO2 is a vasodilator. It will increase how much fluid gets to the brain, and it would make the increased intracranial pressure worse. This patient is probably going to be on mechanical ventilation so that we can control how much they are breathing, and also because they're probably going to be sedated, and we're going to talk about that in just a little bit. So, we also want to prevent shivering. We want to prevent shivering because shivering is going to increase intracranial pressure because it's going to increase. Okay, check this out. Which, okay, your brain needs oxygen to function, correct? Yes or no?
Yes.
Okay. Do you think that there's certain things that you do that would make the brain require more oxygen? For example, which one do you think your brain is going to use a lot of oxygen for? Sleeping or taking the NCLEX? Do you think your brain requires more oxygen when it's doing more complex tasks? Absolutely, absolutely. So the more complex the task that your brain is executing, the more oxygen is going to need. So basically, the more your brain is being used, the more oxygen it needs. So when you're sleeping, your body is at rest. Yes, your brain is still functioning, but on a lesser level versus if you're taking the NCLEX or you're driving on the highway and it's raining and you're really focusing, right? So the more your brain is functioning, the more oxygen it needs. So, somebody with increased intracranial pressure, do you think that we should want to promote rest? Absolutely. Because if we promote rest, the brain is at rest and the brain needs less oxygen. Versus, let's say If the patient has intracranial pressure and they're taking the NCLEX, their brain is working more, correct? And if their brain is working more, their brain needs more oxygen, correct? And if the brain needs more oxygen, how does oxygen get to the brain? Does it like, does it fly over there magically? Or does oxygen have to travel in the blood? In the blood. Is blood a fluid? Is blood a fluid? Yes, absolutely. So, the more that the brain is being used, the more it's functioning, the more oxygen it needs. The more oxygen it needs, the more blood flow it needs. The more blood flow that it needs, the more fluid that will go to the brain. So, when the brain is being used too much in a patient with increased intracranial pressure, we're going to increase how much fluid the brain gets, and that's going to make the intracranial pressure worse. It's going to make it higher, and that's going to lead the patient to death. So that's why we want the brain at rest. Because when the brain is at rest, the less oxygen it needs to consume, the less fluid that will go to the brain. So that's why we want to decrease environmental stimuli. So someone with increased intracranial pressure, do you want the lights on or low? Do you want bright lights in the room or do you want dim lights? Low or dim. Very good. Because the brighter the lights, the more the brain is functioning. You don't, okay, you don't want to stimulate the brain for somebody with increased intracranial pressure. You want to reduce any stimuli because you want the brain to rest. So the brighter the lights, the more stimulated the brain. So we want dim lights. Do we want loud noises or do we want to promote a quiet environment? A quiet environment. So we're building this type of environment where we have decreased environmental stimuli, where the lights are low or dim. The environment is very quiet. Do we want a lot of visitors? A lot of talking? No, we want a quiet environment. Also, we want to reduce activities that would increase oxygen consumption, like shivering. Shivering is going to shivering, your body is moving. When your body is moving, your body needs oxygen, and that would make ICP worse. So we want to prevent shivering. So shivering happens when the patient is cold. So we're going to control the temperature of the room. We don't want it too cold. And also, there's medications that we can give them that would help to relax the muscles so that they don't shiver. Okay. Also, we want to avoid actions that would increase the intracranial pressure, like straining. So straining is when it's like you're constipated, right? And you're squeezing. So that would definitely, even if you pretend to do that, you could see how that would increase the pressure in the head. So, stool softeners, no coughing, no sneezing. So these would be easily controlled in the patient that is sedated. And we're going to talk about that. No bending. Again, a sedated patient on mechanical ventilation. You don't really have to worry about those things. And no Valsalva maneuver, which is bearing down, which is like acting like you're pooping. So none of that. Okay. Um, for increased ICP, we want the bed like semi-Fowlers, like 30 to 40 degrees. No Trendelenburg. So Trendelenburg is head down, feet up. We don't want that because all the blood would go to the brain. That would definitely increase ICP and make the issue worse. Okay, so here are some types of medications that would be used in the management of a patient with increased ICP. So anti-seizure medications. So anti-seizure medications are given prophylactically to prevent seizures. Okay? Seizures can increase metabolic requirements in cerebral blood flow and volume, and that would increase ICP. So they often give anti-seizure medications to prevent seizures. Antipyretics, fever would definitely increase cerebral blood flow because fever would increase the temperature. Fever is an increased temperature of the body, and that is going to increase the metabolic rate in the brain, and that's going to increase oxygen consumption. So they give antipyretics to prevent temperature elevations and muscle relaxants to prevent shivering. Okay, remember, we want the brain and the body in a state of rest when a patient has increased ICP. Blood pressure medication may be required to maintain cerebral perfusion at a normal level. Corticosteroids stabilize the cell membrane and they decrease cerebral edema. IV fluids are administered via IV pump to control how much IV fluids they're receiving. And a hyperosmotic agent like mannitol. Mannitol is an osmotic diuretic. We're going to learn about it. And that helps to remove fluid from the brain. So that would help to reduce increased intracranial pressure. Okay. Next up, page 125. Traumatic brain injury, but you know what? First, I forgot. We're going to do some questions, okay? So hang on a second. Okay, so number one, the nurse has established a goal to maintain intracranial pressure within the normal range for a client who had a craniotomy 12 hours ago. Can somebody tell me what is a craniotomy, like in just very simple terms? What happened? Brain surgery, right? A craniotomy. So the cranial is like the cranium, which is the skull, and otomy, like they made it like an incision or a hole. So craniotomy, they cut the skull open, and that's usually to reduce intracranial pressure or to do brain surgery. So the nurse has established a goal to maintain intracranial pressure within the normal range for a client who had a craniotomy 12 hours ago. What should the nurse do? Select all that apply. All right. So, would you encourage that? So, okay, I have a question for you. So, a patient, we just said, what did we say the craniotomy is? We said the craniotomy is basically like brain surgery, right? Very good. Okay, so do you think um, the patient is at risk for increased intracranial pressure after having brain surgery? So, as a nurse, what would your main goal be for ICP in a patient after they had brain surgery? Like, what's your goal? Like, I know it is to keep it normal, like 7 to 15, right? Um, but give me your main goal in one sentence for this patient to prevent what? Very good. So, okay, so is it safe to say that your main goal for this patient is to prevent increased ICP? Okay, got it. Okay, so let's go through each one and tell me if this would prevent increased ICP or could it cause increased ICP. So, one, encourage the client to cough to expectorate secretions. Would that prevent increased ICP or cause it? So, coughing would definitely increase intracranial pressure, correct? So we don't want to encourage them. So remember, it said, what should the nurse do, right? So we're looking for the correct things to do, right? So we don't want to encourage the patient to cough because coughing would increase ICP. So write that down if you got that one wrong. Coughing would increase ICP. What about choice number two? Elevate the head of the bed 15 to 30 degrees. Would that help? Like, what degrees of the bed did we say that the patient should be, the head of the bed should be elevated to? What degree? We said 30 to 40, right? So 15 to 30, that, would you do it? I know this one is tricky. It's not fair, but it's correct. You know, the 30 degrees is what makes it safe, right? Because we said 30 to 40. This one says 15 to 30. So this is correct. Okay. Would you contact the healthcare provider if the ICP is greater than 20? Yes, very good. So if it's 21, if it's 22, it's too high, you have to alert the healthcare provider so that they can give you a plan of action or make a decision on what to do or prescribe. What about monitor neurologic status using the Glasgow Coma Scale? Very good. Please do that. Please, in Jesus' name, do that. Okay. Because you want to monitor and like, okay, so let's say they just got back from the, well, they had the craniotomy 12 hours ago. But either way, do you want to do the Glasgow Coma Scale right when you get the patient? Yes or no? Yes, right away when you get the patient, because you want to establish a baseline. So you know, like, okay, when I got the patient, their Glasgow Coma Scale score was 8. And then let's say in an hour again it's 8, in an hour it's 8, in an hour it's 8, like, or in an hour it's 9, whatever. You want to monitor it, right? Because you don't want, like, you didn't do the Glasgow Coma scale and then you do it randomly at 12 and it's 8, and then you do it again at 4 and it's 3. Like, no, you want to know what it was right when you started caring for the patient, and you want to monitor it frequently so that you can monitor for any sudden changes or improvements, or that the patient is declining. You want to know those things. Do you want to know what the Glasgow Coma Scale score was in the nurse before you? Absolutely. You want to know, is this a no, is this how the patient has been? Or was there a sudden change? So that if the nurse before you was getting a Glasgow Coma Scale score of 12, I'm just making up numbers by the way, of 12, and you keep getting 8, you're like, well, what happened? Okay. And then final option, do you want to stimulate the client with active range of motion exercises? Very good. Very good. Remember, in a patient who is at risk or has increased intracranial pressure, we don't want to stimulate them. We want the brain and the body at rest, because that is going to cause the brain to use less oxygen, and the less oxygen it needs to use, the less blood flow that is going to require. The less blood flow, the less swelling, right? But the more the brain is stimulated, either through light or noise or activity, the more it's stimulated, the more oxygen it will need, the more blood flow it will need, the more swelling, that intracranial pressure is going to increase, and that's going to compress the blood vessels, and the brain tissue won't get enough oxygen. The brain tissue will die. The patient won't breathe enough, and then the patient will die. We want to avoid that, okay? So remember, you have to study very well what we learned about increased intracranial pressure. No coughing, no straining, no shivering, no bending, okay? Even vomiting we want to prevent, okay? The nurse is monitoring a client with increased intracranial pressure. What indicators are the most critical for the nurse to monitor? Select all that apply. This is a good question. Mm, So nobody got it right. And so there's some key words here. Here, let me make it red. So now that I've underlined that keyword, now, because nobody got it right. So what's the answer? It's select all that apply. What are the answers? Mm, remember, mm, okay. The information that's going to help you is the information that's going to help you monitor if the condition is getting worse, better, or worse. So let's go through each one because you guys are really strong, but this one nobody got it right. So the nurse is monitoring a client with increased intracranial pressure. What indicators are the most critical? Most critical. So when you see that on the NCLEX, that means what information is going to tell you, is my patient getting better or worse? Did we not say that you can monitor the patient's vital signs and it can help you to determine if they're at risk for increased intracranial pressure or if they likely have it? Didn't we say Cushing's triad? Yes or no? And didn't we say that the vital signs of increased intracranial pressure are the exact opposite of the vital signs of shock? And so with shock, blood pressure is low, so increased ICP blood pressure is high. So if you monitor blood pressure, it can tell you if your patient is getting better or worse because they already have increased intracranial pressure. It says the nurse is monitoring a client with increased intracranial pressure. So they already have it. So monitoring their blood pressure is going to help you to see like, okay, if it's getting higher, the intracranial pressure is getting worse. Or if the blood pressure is normal, you can say like, well, that's a good sign. Let me keep monitoring. Okay. What about urine output? Would you monitor that? No, because what is it for this situation? What is that going to tell you? Yeah, I know it says systolic, just the top number, but that's really what you're looking at, right? That's really what you're looking at. Um, but urine output, that's not going to give you anything that's going to help the patient right now. That's just going to tell you like, oh, the kidneys are working, right? Or not. Breath sounds, would you monitor? Is that the most critical indicator for you to monitor in this patient right now? No. What is it going to tell you? If it said respiratory rate, I would choose that. But breath sounds just tell you like if there's like crackles, like fluid in the lungs or mucus in the lungs. So just think about when you get a question like this on the NCLEX, and you will, and you'll get it right. When it's saying what's most critical or most important for the nurse to monitor, it's what information is going to tell me, is my patient getting better or worse based off of what they're going through. What about cerebral perfusion pressure? It is tricky. This question is tricky, but it's a good question because this type of question will prove to you that even if you don't know every single thing about that question, you can still get it correct if you use your critical thinking. Break and let's say you've never seen that term before in your life, cerebral perfusion pressure. You've never seen it before. What does cerebral mean? Brain. What does perfusion mean? Very good. Circulation. I love that. Very, if you're thinking like that, you have a very good understanding of this content. Very, very good. You have good critical thinking skills. So cerebral perfusion pressure, it's the pressure at which the brain is receiving blood flow. Don't you think that's closely related to ICP? It is, okay? So cerebral perfusion pressure is very closely related to ICP, okay? And then what about the level of pain? I mean, yes, it's important for the patient, but is that the most critical thing? No. Because how is that going to tell you if your patient is getting better or not? It won't tell you anything about, because it's asking about the increased intracranial pressure. What can you monitor to help you figure out if the patient is getting better or worse? So it would be systolic blood pressure and cerebral perfusion pressure. Okay. All right. So you guys did okay. Remember what we just learned in the study guide. Make sure you study and you memorize it so that you can be prepared for those questions. All right, guys, let's take a 5-minute break. And when we get back, we're going to learn about seizures and the seizures medications you need to memorize for NCLEX. Excuse me, stroke. We're going to learn about stroke and then seizure. Thank you. So someone said for ICP, don't monitor pain. You can, but that's not the most critical. Okay? So the most critical out of those choices would be the blood pressure and the cerebral perfusion pressure. Pain is not really going to tell you if the patient is improving or not. Okay? All right, guys, so let's take a 5-minute break and then we're going to go to page 126 on the study guide. Stroke. All right, so we are on page 126, neurological diseases and disorders. So stroke is known as a cerebrovascular accident. So there's two main types of stroke, ischemic and hemorrhagic. So ischemic is when the brain tissue cannot get oxygen because of a clot. And then there's hemorrhagic, where blood from an artery begins bleeding in the brain, and it is caused because the artery burst. So it is very, very important for you to know that hypertension is one of the leading causes of stroke. So please, please, please make sure you understand why hypertension is a silent killer, because we may not know that the blood pressure is so high until the patient has a stroke because of it. Okay? So please, please, please make sure you understand the importance of why we have to keep our blood pressures healthy, our family members, we have to educate them about this, our loved ones, our co-workers, our patients, because high blood pressures kill patients every single day when it can be prevented through proper diet and exercise and lifestyle changes. We don't want our patients to have a stroke before we realize that they had high blood pressure that was uncontrolled or being improperly managed. So signs and symptoms of a stroke, it depends on the area of the brain affected. However, for the most part, usually you may see facial drooping, slurred speech, blurry vision, and paralysis, numbness and tingling of an extremity. So it is very important to educate patients and family members that if they see any of these signs, to call 911 immediately. The major goal in stroke treatment is to get them to a CT scan, or they could do MRI. But the CT scan is going to identify which type of stroke the patient had, so that if they can figure out, was it an ischemic stroke or was it hemorrhagic stroke? Okay. Other main priorities. So this is okay. This is something where it's like there's two major number one priorities for your patient who you suspect has had a stroke. So let me get this. Hold on. Okay. The two main priorities for a patient suspected of having a stroke. Okay. Please write that down and memorize that. That is so essential for you to know. Um, Number one, because a stroke can affect the patient's ability to protect their airway. A stroke can also affect the patient's ability to swallow. So stroke can lead to aspiration and blockage of airway. And time is brain. Okay? So I always tell my students that stroke has two number one priorities. You know how I always say the number one priority is airway, the number two priority. Stroke has two number ones, airway and time. So we want to protect the airway to make sure that they're not choking on any secretions, because then if they're not getting any oxygen in their body at all, they're going to die before they even get to the ambulance, before they even get to the hospital, right? But also keeping in mind time. So the moment anyone sees the signs of stroke, the drooping, the slurred speech, the paralysis, the blurry vision, all of a sudden, can't speak, things like that. Time is brain. So the more time that passes by without proper treatment for the stroke, the more brain tissue can die. Okay, and I meant to put treatment. Excuse me. Okay. So please keep that in mind Now, remember, we said it is very important to get to the patient to the CT scan. In the hospital, we call that a code gray, um, or a stroke alert. They would say, stroke alert. That tells uh, the CT staff or the radiology staff that they're going to need to be doing a CT scan on someone, and they need a bay or bed available in the CT room to do that. Um, so important to know, a mini stroke is called a TIA, or transient ischemic attack. The symptoms of the stroke came on, but then they went away. So that is a sign that the patient needs to make some lifestyle changes, because next time it could be a real stroke, God forbid. Opposites attract. A right-sided brain stroke causes left-sided paralysis. A left-sided brain stroke causes right-sided paralysis. Aphasia is when the patient has difficulty speaking, and so we want to make sure that we give these type of patients one task at a time, um, and that we give them directions clearly, give them time to communicate, and use a picture board. The other important thing I want you to know is I want you to know the difference between dysphagia. Excuse me, I'm using like a keyboard that I don't use all the time. So, okay, and then this. So you can just think that the G in dysphagia is for gastric, okay? Because when you're swallowing, you're trying to put something in your stomach, right? Whenever you're swallowing, you're trying to put food or liquid in your stomach. So dysphagia is difficulty swallowing, and then dysphasia is difficulty speaking. Okay. Also, make sure you know the therapies that we use. So we use speech therapy, um, and they help with swallow study, and also with speech rehabilitation. And then we use PT for strengthening, especially if they have like a paralyzed side. And then we have occupational therapy, which will help them with their ADLs with their hands. So like buttoning, zipping, using utensils. Okay. So speech therapy is very important because after a stroke, it can affect the ability to swallow and cause dysphagia. So swallow study is going to help them determine whether the liquids need to be thickened, like regular consistency, nectar consistency, honey, and then or even pudding consistency for the fluids, and then for the foods, if the foods can be regular or if they need to be mechanical soft or pureed or ground. And then they do speech rehabilitation. So if they're having that difficulty speaking, that they can help the patient to speak as close to baseline as possible. And then physical therapy helps with strengthening, especially if they had like have a paralysis on one side of their body, how to get that side as strong and as close to baseline as possible. And then occupational therapy, they help you perform your activities of daily living, and they work with the upper body. So buttoning, zipping, using fork and spoon and cup. Okay. Medications you need to know for stroke is TPA. TPA is for ischemic stroke. Okay? TPA is for ischemic stroke. It is a super clot buster. So ischemic stroke is because of a clot. So the TPA is going to dissolve that clot. Okay, and so it is very important to know that you cannot give it for hemorrhagic stroke, and also that afterwards you want to monitor the blood pressure because a high blood pressure after giving TPA can lead to brain bleed. Okay, so remember this is recorded. You can go back and listen to this so that you're not missing anything. Okay, it is very, very important. The things that we're talking about today, you have to know this for the NCLEX in order for you to pass. Also for TPA, make sure you know that only 3 hours can have gone by from when the symptoms started. So for example, right now it's 11 o'clock in the morning. So that means if the patient comes into the emergency room and said that they started having symptoms of stroke at 2 o'clock in the morning and they do the CT scan and they had an ischemic stroke, can they get the TPA? Yes or no? So again, the question is, it's 11 o'clock in the morning right now. The patient comes into the emergency room right now, 11 o'clock in the morning, and says since 2 in the morning they were having symptoms of stroke. We do a CT scan and it says that they had an ischemic stroke. Can they get TPA? Are they a candidate? No, because too much time has passed, right? So if it's 11 o'clock right now and they say that the symptoms started at 8 in the morning, then they are a candidate for TPA. What about if it's 11 o'clock in the morning right now and they say that the symptoms started at 9 in the morning? We do a CT of the head or the CT of the brain and they had a hemorrhagic stroke. Can they get TPA? No, because TPA is only for ischemic stroke. If we give a patient who had a hemorrhagic stroke TPA, they will bleed to death. Okay? All right, so let's do a couple questions on stroke. Okay, I know it doesn't have question 42, like the numbers 42 here, but here's question 42. So this is a very good question. And this will tell me if you remember what we learned last class. A client is being monitored for transient ischemic attacks. The client is oriented, can open the eyes spontaneously, and follows commands. What is the Glasgow Coma Scale score? Very good. Very, very good. So it looks like only one person remembered what we learned last class. So remember, Glasgow Coma Scale score is how many categories? It's 3 categories, right? And what are we testing? Eye opening, verbal response, motor response, right? And you can get a score as low as 3 or as high as 15. Very good. So this patient is oriented, they open their eyes on their own and they follow commands. That's the best you can do neurologically. So that's an automatic 15, right? So do you see? Exactly. So this is an example of something you might see integrated into a question on the NCLEX, where it's just, so there's questions you know it or you don't. And then there's questions where you can use your critical thinking to get through. So this is one where you either know it or you don't. So those are the things that I'm telling you when you have to read the book and you have to read the study guide and you have to memorize it. This is an example of something that you have to memorize if you want to pass the NCLEX. Okay, so 45. A client arrives in the emergency department with an ischemic stroke and receives tissue plasminogen activator administration. The nurse should first, what would you choose if this was the NCLEX? Very, very, very good. You guys have got it. So this is a type of question you can expect to see on the NCLEX. Actually, all three of the next questions that we're gonna do, including this one, this is what you can expect to see. Very simple, and believe it or not, people think like, oh, because of the case studies now, the questions are all like complex. I'm telling you, the NCLEX questions are very straightforward. And if you have a good foundation, it will look like just like a normal homework question to you because you have a strong foundation and you know what to zero in for. TPA is time, the time of onset of the stroke, because we have a 3-hour window from the onset of symptoms to the patient is in front of us. Okay? 40, so very good. 45, the correct answer is 3. 46, during the first 24 hours after thrombolytic treatment for an ischemic stroke, the primary goal is to control the client's what? Very good, guys. Very good. So when they say like thrombolytic treatment, that means the clot buster, TPA. So that means the patient had an ischemic stroke. We gave them TPA. Afterwards, we have to monitor blood pressure because if the blood pressure is too high, the the TPA is like kind of like a blood thinner, kind of in a way, and then so therefore it makes the blood more thin. So the patient, if they have a high blood pressure, is at risk for a blood vessel to rupture in the brain, and it can easily lead to a brain bleed. So 46, the correct answer is 3, blood pressure. Very good. Everyone have a good understanding of those first two questions because this is that level of difficulty is 90% of your NCLEX. This is what 90% of your NCLEX looks like. Even if it's disguised as a case study, even if it's disguised as a case study, this is the level of difficulty of the NCLEX where it's very straightforward. I call it a straight shot question or a straight shooter question. If you have the foundation, the answer comes easily. Okay? 47. What is a priority nursing assessment in the first 24 hours after admission of the client with a thrombotic stroke? This is a good, oh my gosh, these are some good questions. If you get these questions right, you're going to pass the NCLEX. Very good, very good. Number two, this is a neuro patient. They had a stroke. This is a neurological patient. And so you're going to focus on what is going to give you neurological assessment data. So pupil size and how well the pupils are responding, that's going to let you know that. So if the pupil size and pupil response is normal, that's going to let you know that neurologically the patient is doing well, and that's going to let you know how they're doing after the stroke. So very, very good. And also, stroke is neuro, cholesterol is more cardiac, bowel sounds is GI, echo is cardiac. Pupil size and pupillary response, that's neuro. So the patient has a neuro problem, and we're looking at something that's going to give us neuro information, right? Very, very good. Okay, let's do one more question, and then we're going to, oh my gosh, this one is so annoying. I don't like this question, but it's important to build on your critical thinking skills. A client with a, this is what I call an unfair question. You might see something like this on the NCLEX, especially as a case study, and it's annoying because there's so many ways that which one can be right or wrong. It's very annoying. But this is reality of NCLEX, so we have to practice these. A client with a hemorrhagic stroke is slightly agitated. The heart rate is 118. Respirations are 22. Bilateral bronchi are auscultated. The oxygen saturation is 94%. Blood pressure is 144 over 88. And oral secretions are noted. What order of intervention should the nurse follow when suctioning the client to prevent increased ICP and maintain adequate cerebral perfusion? Take your time. I'm going to give you 3 minutes to do this and then put your answer. So this is what would put it in order. Okay. Let's let a couple more people answer. That's why I was saying this question is so annoying. I don't like it. Come on, guys. A couple more people should answer so I can see if you're understanding the content. No, it's not select all that apply. It's put in order. So remember, guys, if you're not answering, I don't know if you're understanding it. And then I don't know if I need to go over something again. Okay, so the correct order is 4, 2, 1, and 3. Okay, so let's read this again. A client with a hemorrhagic stroke is slightly agitated. So, anytime you see the word, so write this down. Anytime you see the word agitated, anxious, or restless, I want you to think, check O2 sat and blood sugar. Okay. So, and again, excuse me, I'm fighting for my life with this keyboard because I don't use it all the time. Okay. So anytime you see those keywords on the NCLEX, agitated, anxious, or restless, I want you to think, is my patient's oxygen level okay and is their blood sugar okay? Because those are signs that something is wrong. It's not normal. Like if it says the patient is mad, like they're a psych patient and they're mad and agitated, that's one thing. I'm talking about like a medical patient. If a medical patient is agitated, anxious, or restless, check those two things. Now, heart rate being up, respiratory being up, bilateral rhonchi. Rhonchi equals mucus in the lungs. So, do you think if a patient, so if you hear rhonchi when you listen to lung sounds, that means there's mucus in the lungs. Do you think if there's mucus in the lungs, that that's going to affect how much oxygen can get inside the lungs? Yes or no? Very good. Now, do you think there's mucus in the lungs that's going to reduce how much oxygen can get in? Do you think the person is naturally going to breathe faster to try to bring more oxygen in? Okay, very good. So there's some type of compensation, right? So this tachypnea, this respiratory rate of 22 is what we call compensatory. It's a compensation mechanism where it's like the body's like, wait a minute, I don't have enough oxygen. So let's try to breathe faster and get more oxygen in. And then the heart beats faster to try to deliver more oxygen to the tissues a little faster. The body's kind of slightly panicking at this point. Okay. Now, do you think it's because they have oral secretions? Remember, I told you somebody with a stroke, they're at risk for aspiration. So we need to suction the patient. Okay. Now, the order, we're going to provide sedation. So increased agitation with suctioning will increase the ICP. Therefore, because suctioning is going to increase the ICP period, write that down. Suctioning increases ICP. Mouth care increases ICP. Suctioning increases ICP, and so does oral care. So that's something to keep in mind when you're taking care of a neuro patient who either had brain surgery, has increased ICP, or has a condition that places them at risk for increased ICP, like a hemorrhagic stroke. A hemorrhagic stroke, a blood vessel burst in their brain and they bled out. So that's increased fluid in the brain, increased volume in the brain, and that's going to increase the ICP. So they're already at high risk for increased ICP. So increased agitation with suctioning will increase the ICP. So the patient needs suctioning, but because they're agitated and maybe moving around, that's going to increase their ICP. Therefore, we have to provide sedation first. And we could do that through medication. Propofol, boom. The patient should be hyperoxygenated before. So we're going to learn that when we get to respiratory with an ambu bag to prevent hypoxia. And then the airway should be suctioned for no more than 10 seconds. The mouth should be suctioned once the airway is clear. So you suction the airway first and then the mouth. and then you discard the catheter, the suction catheter. So we're going to learn about suctioning when we get to respiratory, but this is just a good thing for you to understand these key principles. Anytime an NCLEX question says agitation or restlessness, check O2 sat and blood sugar. Rhonchi means mucus in the lungs. That reduces how much oxygen is getting in. So the body's going to compensate with a rapid respiratory rate and a high heart rate. Um, you always want to sedate the patient, sedate a patient who is at risk for increased ICP before you suction them. You want to anytime you're going to suction a patient, you have to hyperoxygenate them and give them oxygen. We don't want to cause hypoxia. Then we always suction the airway and then the mouth. Okay. All right. Very good. Let's do seizures. Okay, seizures. We're on page 127 of the study guide. Seizures are abnormal and excessive electrical activity in the brain. Okay, so if somebody has a chronic history of seizures, we call that epilepsy. If they have back-to-back seizures and they don't regain consciousness in between, we call that status epilepticus. This status epilepticus is an emergency because they're having back-to-back seizures. When a patient is seizing, they're not breathing. Okay, so aura. Make sure you know what aura is. Aura is the client feels a seizure is coming on. Okay. Interventions, you stay with the patient. Do not restrain the patient. Protect them from injury. So we don't want to like hold them because they can like break a bone or something. But if they're about to hit a table, move the table. Always keep the airway open. Do not force the jaws open. Do not put anything in the mouth, so no tongue depressor in the mouth. Prepare to suction secretions. If the patient was sitting or standing, help them to the floor and protect their head and body. So if they were standing and then they have a seizure, help them to the floor. Don't hold their head, but if their head is about to hit the nightstand, move the nightstand. Turn the patient on their side so secretions can drain. Loosen restrictive clothing. Monitor time and duration of the seizure. Monitor movements and monitor for incontinence. A client with a history of seizures should wear a medic alert bracelet. Give me one moment to put a picture up for you. Okay, can everyone see this picture? Let me know in the chat. Okay, so definitely take a picture of this. So this is what we call seizure precautions. So let you take a picture and then we'll discuss this picture. All right, so seizure precautions. Number one, we always want the side rails up and padded. So remember, we can't put all four side rails up because then that's considered a restraint, but we can put three up. And then we want those side rails padded so that if they begin having a seizure, that it's padded for their safety, that they don't hit their head or hurt themselves. You want a pillow under their head to protect their head from, you want to protect their head from the headboard. Also, you want them elevated so that they're not just laying flat and can choke on their secretions. You want them in a side lying position so that if they begin having a seizure, that they're already on their side and the secretions can come out. You don't want them to choke on their secretions. You want the bed in the lowest position so that if they do fall, they fall from a lower height and that will decrease the risk of injury. You want loose clothes on them. You don't want any tight clothing that can get stuck on something and choke the patient. You want oxygen and suction ready so that when they do stop having the stroke, the stroke, when they do stop having the seizure, we are ready to suction immediately. Also, you want privacy provided so that they have a curtain or a door that can be closed so that when they are having the seizure, we're with them and ready to take care of them and keep them safe. However, we can give them their privacy. Okay, now let's talk about the medications. So medications, I would memorize these three for seizure, anti-seizure medications: phenytoin, carbamazepine, and levetiracetam. So phenytoin, make sure you know, say this with me, Fen-10, Fen-10. Okay, so phenytoin, I want you to think Fen-10. You want the therapeutic range between 10 and 20. So I think like the Fen-10s. Instead of saying phenytoin in my head, I say phenytoin. And then I think that when you check their blood level to see if they have enough of it in their blood after taking it for some time, it should be 10 to 20. Um, Carbamazepine and levetiracetam. So memorize those. All right, so let's do some questions on seizure. All right, question 24. The nurse sees a client walking in the hallway who begins to have a seizure. The nurse should do which of the following in priority order? So put the following steps in order of what you should do if the patient begins having a seizure. All right, so very, very good. We've got some right answers. So 3, 1, 4. Oh, what I do? 3, 1, 4, and 2. Okay. So the to protect the client from falling, the nurse should ease the client to the floor. It is important to protect the head and maintain a patent airway since altered breathing and excessive saliva can build up in the airway. The assessment of the post-ictal period should include level of consciousness and vital signs. So after the stroke, we check the vitals. And then you record the details of the seizure once the client is stable. Um, Also, I want you to know what this word means. So aura is before the seizure, and then post-ictal sleep, post-ictal period is after the seizure. Okay. And then after the seizure, they usually have something called a post-ictal sleep, where they sleep, they rest after the seizure. So remember, the aura, it happens before the seizure. It's like a premonition. Tokuyo sansila koyo ke they're about to have a seizure. They feel like a weird feeling, like it's gonna happen, and then the seizure happens. Anything after the seizure is called the post-ictal period, and afterwards they're probably gonna go to sleep. Okay, next question. Which of the following is contraindicated for a client with seizure precautions? Right. Somebody said if the patient was in the hallway. And sorry about that, guys. I didn't know they were going to come cut the grass right now. Very, very good. Very good. Very straightforward with that one. So remember, a patient on seizure precautions, write this down. A patient on seizure precautions. So they have a history of seizures or they're at risk of seizures right now. A patient on seizure precautions. No oral or rectal temperatures. Why? Because they can start having a seizure while the thermometer is in their mouth or their rectum, and it can cause trauma. For example, they can have a seizure while you're checking the temperature in the mouth and bite on the thermometer, and it can damage their mouth or their throat. They can cause a cut, a bleed. They can start to choke on the thermometer. In their rectum, if we're checking their temperature and they start having a seizure, it can break and it can lead to rectal tear or rectal trauma. Okay? All right, very good with the seizure question. So we don't check the temperature while they're having a seizure. We check the temperature and the vital signs after the seizure. After anything like mean to touch the patient's body, it would be after the seizure is over. And then so if they are on seizure precautions, we can check the temperature underneath the mouth, uh, underneath the armpit, excuse me, like axillary temperature, or like on the forehead, tympanic. Temporal. Oh my gosh, excuse me, guys. I'm so sorry. Let me type that. Please forgive me. Okay, correct ways to check temperature for seizure precaution patient. You can do axillary, which is under the armpit, and then you can do temporal, which is the forehead temperature. Okay, I wouldn't check the vital signs during a seizure. I think all the movement, the machine might not even read it, and then if it did, it might be very high. Um, Yeah, we wouldn't do that though, because they can hurt themselves with the cord of remember, like their muscles are seizing, so to be a lot of strength in rigid movements. So you would definitely want to check the vital signs after the seizure is over. All right, guys, so let's go back to the study guide. Okay, so we're on page 128, multiple sclerosis. So multiple sclerosis is a chronic disease where the covering of the neurons begins breaking down. So this is a chronic disease where they can have periods where the symptoms improve, which is called remission, or get worse, which is exacerbation. So you're probably going to see the patient more when they have an exacerbation. That's when they're going to come into the hospital with a lot of discomfort. So, some things I want you to know, the cause is unknown, but it can be autoimmune, which means the person's own body is attacking itself. So, multiple sclerosis, fatigue, weakness, numbness, blurred vision, and double vision. And please write down incontinence, which as a nurse means you have to protect skin integrity. Okay. Also, for fatigue and weakness, what would be your number one priority? Safety, right? Blurry vision, safety. So the major priorities when taking care of multiple sclerosis patient is safety and protect their skin. Remember, they're very, very tired. So we want to encourage them to conserve their energy, like having rest in between periods. So they might not be able to do an activity for 10 minutes. No, maybe they can do 2 minutes worth and then take a 5 minute break and then try again for another 2 minutes. If they're having the double vision, give them an eye patch. Okay? Medications, rituximab or Rituxan, it is used to treat autoimmune disorders and it's given IV very slowly. Okay, so multiple sclerosis, just make sure you understand the symptoms and your two major nursing priorities, safety and protect the skin. Let's do a question on it. And remember, guys, this is recorded, so I don't want you to feel overwhelmed. Okay. Oh, hold on a second. So someone in the chat said it's confusing. Tell me what's confusing, and then I'll explain. With the seizure. Okay, so what is confusing about the seizure? Oh, I think you're confusing seizure with stroke, my love. Okay, so you're saying that it's confusing that, yeah, I think you're confusing seizure with stroke. So remember we said if the patient had an ischemic stroke and they got TPA, that afterwards you want to monitor the blood pressure because it can be high. So that's stroke. But seizure, you don't want to take the vital signs while the patient is actively having a seizure because you can harm them. You want to wait till the seizure is over and then you check the vital signs. So, stroke is different from seizure. Does that help clarify? I got you, okay? All right. All right, so let's do two questions for multiple sclerosis. I'm sorry, guys. Hold on, my computer is. One moment, guys. Just a little technical difficulties with the pages. Um, okay. All right. So the nurse should conduct a focused assessment with the client with multiple sclerosis for risk of which of the following? Select all that apply. What would you choose if this was the NCLEX? I'm sorry, guys. The lawnmower outside is driving me crazy. I can't focus. Okay. Very good. Okay, so the correct answers are 2, 4, and 5. Okay, so we didn't say that a patient with multiple sclerosis is at risk for dehydration. Um, But we did say that because of the weakness and the fatigue, that they are at risk for safety concerns, right? We didn't say that multiple sclerosis is at risk for seizures, but they are at risk for skin breakdown because of bladder incontinence. Okay. Next, we're going to do one more question for multiple sclerosis. That this is what I call a learning question, and you'll see why. So a client with multiple sclerosis is receiving baclofen. The nurse determines that the drug is effective when it achieves which of the following? So what would you choose if this was the NCLEX? Very, very good. So this is a learning question, which is, sometimes we'll learn what we need to learn to answer questions during like in the study guide, and sometimes we'll learn things through the questions themselves. So yes, baclofen is a muscle relaxant, and so this will help to relieve any muscle spasticity they will have. So very good. So just know, but we're going to touch on baclofen again in musculoskeletal. um, Very, very good. All right, guys, let's take a 5-minute break. And when we get back, we are going to learn about, let's see which one's next. We're going to learn about Parkinson's disease, trigeminal neuralgia, and myasthenia gravis. All right, so I'll see you in 5 minutes. Thank you. All right, everyone. Please, please, please. I still have two people who their name is just showing up as iPhone, iPad. So I'm gonna give you guys just 2 more minutes to change your name to your name. And then I'm gonna have to put you in the waiting room. Please, 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 just change your name. All you have to do is where it says me, M-E, and then you just press rename and then you change your name. So, um, or you can send me a message in the chat with what your name is. So now we're going to do Parkinson's disease. So write down on your notes for Parkinson's disease, put Parkinson's disease equals PD equals poor dopamine. Okay. Okay, so just one more person. Their name is iPhone, and I don't know who that is. Okay, so Parkinson's disease. I just want you to think Parkinson's disease is because of poor dopamine level. They don't have enough dopamine. So it's due to a depletion of dopamine that leads to issues with muscle tone, posture, and movement. So I'm going to show you a picture of Parkinson's disease. I just have to switch really quickly screens. Okay. Can everyone see that picture of a man? Okay, so please take a picture of that. So Parkinson's disease, remember, poor dopamine. It is because the body does not have enough dopamine. The brain does not have enough dopamine. So they develop something called the Parkinsonian gait, where they have like shuffling steps. So instead of picking up their feet and walking, they're like sliding their feet across. So on moun avek Parkinson's disease, tan kou yo pa leve piye yo chak fwa yo mache, tan kou yo trene piye yo. So sa vle di li fasil pou yo ka tombe a teya. Okay? So Parkinson's disease, that shuffling gait, the shuffling steps, it makes it easier for them to fall, like especially to trip over things. Like if they're walking and there's a rug on the floor, because they don't pick up their feet one after the other, they slide their feet. It's like they can trip easily over things. They move very slowly. So that's what we call, I'm going to write that for you. That's what we call bradykinesia. Okay? Brady means slow and kinesia like movement. So they move very slowly. So you have to give them time. Okay? Don't rush them. Also, their body is very rigid. And sometimes as they're walking, they freeze. Postural instability. So all of these things put them at risk for falling. Their positioning is very unstable. Also, they have a tremor in their hand, and they can have a mask-like face. So let me show you what a mask-like face means. Okay, and these pictures are a little sad. It's very sad. It's a very, very horrible disease. I wouldn't wish that on anybody. Um, it's so sad. I don't like looking at this picture. So someone with Parkinson's disease, you can throw a bucket of water in their face and their face won't change. Like they're not going to close their eyes. So like their face before you throw the water in their face and after is the exact same, a mask like face. They're not going to close their eyes, close their mouth. They're not going to squint or, try to protect their eyes. Their face stays the same. So like her face looked like this before you threw the water on it, it's gonna look like it during and after. That's what you call a mask-like face. Okay? So those are the symptoms of Parkinson's disease. Okay? So let's go back to the study guide. So, assessment, the shuffling steps, the bradykinesia, a slowness of movement. Maybe they'll freeze in the middle of moving, which we call akinesia. Tremors in their hand, the pacing. Oh, they love to pace. So they love to walk down a line and then turn around and walk again. So again, that just puts them at risk for fall. And then the mask-like face. So intervention, please don't rush them. They're going to move a lot slower, and it's because of that poor dopamine level. It affects their movement. Assist them with ambulation. They are a high fall risk. Also keep in mind, because they do the pacing uses a lot of energy, so we need to make sure they're on a high calorie, high protein diet. Give them small frequent feedings. um, Sometimes, remember I told you about the freezing where they're trying to move but their body locks up? So sometimes you have to rock them back and forth before you help them to stand up, and then encourage them and educate them to lift their feet while they're walking. So definitely physical therapy can help this patient. Medication, dopaminergics. So remember, in Parkinson's disease, the problem is they don't have enough dopamine. So we're going to give them two dopamine, carbidopa, levodopa. Okay? So Parkinson's disease, poor dopamine, we treat it by giving them dopamine, carbidopa, levodopa. Okay? Also, to help reduce tremors and drooling, we give benztropine. So Parkinson's disease, make sure you remember what causes it, poor dopamine, remember the assessment, how to help them, and the two medications, carbidopa, levodopa, and benztropine. All right? So let's do some questions. And again, guys, I know that it seems that we're kind of zooming through, but it's because I really want to finish neuro today so that we can keep moving at a good pace, okay? But that's why it's good that it's recorded. I recommend, if you feel that it's going too fast, I really recommend that you watch the recording again and then you go over your notes and retake notes as you need to. Okay? All right. Client with Parkinson's disease. Let's see which questions we're going to do. Okay. Question 61. A healthcare provider has prescribed carbidopa levodopa, also called Sinemet, 4 times per day for a client with Parkinson's disease. The client wants to end it all now that the Parkinson's disease has progressed. What should the nurse do? Select all that apply. Okay, we're doing question 61. Put your answers in the chat. Thank you. Okay, so there's still that person where their name is iPhone, so I'm gonna put them in the waiting room, okay? Um, because I don't know who you are, and I've asked you to just send me a message in the chat. All right, guys, so the correct answers are, so you guys are doing good. Oh, let's see. You guys are doing good. Nobody got it fully right though, okay? The correct answers are 3, 4, and 5. So, one important thing for you to know is that you want to make sure that you understand that Cinnamon is not going to treat the depression, it's going to treat the Parkinson's disease, or it's going to help manage it. The nurse should contact the healthcare provider before administering Cinnamon because this medication can cause further symptoms of depression. So, this is a learning question. Suicide threats in clients with chronic illness should be taken seriously. So you want to ask the patient, are you thinking of hurting yourself? And keeping in mind that Sinemet or carbidopa levodopa can make the symptoms of depression worse. Also, you want to make sure you know that you cannot take carbidopa levodopa and an MAOI inhibitor at the same time because it can lead to a hypertensive crisis. Okay? So, um, we don't want to give the patient the medication until we know if they have depression or not. Okay? So take away from that question these things that carbidopa levodopa will make depression worse. You cannot take carbidopa levodopa with an MAOI inhibitor, and you should take the symptoms of if somebody has a chronic illness, if they are displaying being at risk for suicide, you should assess them and take those stats seriously. Okay. 62. Which of the following is an initial sign of Parkinson's disease? This is a tricky question, but let's see what you would choose if this was the NCLEX. So this is 62 is just a multiple choice question. Very good. The correct answer is tremors. So tremors are usually the first sign of Parkinson's disease. And again, these are just learning questions where we might not have learned about it in lecture, but we're reviewing it now and learning about it in the question. Okay. 63. The nurse develops a teaching plan for a client newly diagnosed with Parkinson's disease. Which of the following topics that the nurse plans to discuss is the most important? Very good. The correct answer to 63 is number 3. Very, very good. Can somebody tell me why? Very good, because remember they have that Parkinsonian gait. They have the shuffling steps. They like to pace. They have the bradykinesia. They have the freezing. So they are at risk of falls. They are at risk for falls. So we have to maintain a safe environment. Excellent, excellent, excellent. Safety is the number one priority for the patient with Parkinson's disease. Okay, 66. Which goal is the most realistic for a client diagnosed with Parkinson's disease? So I want to ask you something. Does Parkinson's disease have a cure? No, Parkinson's disease does not have a cure. The correct answer for 66 is number 4, to maintain optimal body function. Okay, so that is the most realistic goal. So helping the client, what happened? Helping the client function at his or her best is the most appropriate and realistic goal. There is no known cure for Parkinson's disease. Parkinson's disease progresses in severity. There is no way to stop its progression. Many clients live for years with the disease. However, it would not be appropriate to start planning for terminal care at this time. Okay, a couple more questions. 68. A client with Parkinson's disease is prescribed levodopa therapy. Improvement in which of the following indicates effective therapy? And this is a learning question. Very good. Very good. If you got this question right, you have good critical thinking skills. Very good. So it won't have any effect on mood, appetite, or alertness because those aren't issues with Parkinson's disease. They have issues with movement and the rigidity and posture. Very good. Okay, last question. Okay, and this is another learning question. A new medication regimen is prescribed for a client with Parkinson's disease. At which time should the nurse make certain that the medication is taken? Very good. At the time scheduled. Perfect. 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 All right. So very good. So that's Parkinson's disease. Next up is trigeminal neuralgia. So trigeminal neuralgia is a disorder to cranial nerve 5 and it causes sharp severe pain along like the cheek area. So it's severe pain on the lips, gum, severe pain in the lip, gum, nose, and across the cheek area. Washing the face and chewing and extreme temperatures make it worse. So what we can do for this patient is avoid hot and cold foods. We want room temperature foods, soft foods, and we want to tell them to chew on the unaffected side. Okay? Memorize that, you'll be good to go. Myasthenia gravis. Myasthenia gravis, I want you to think, okay? So myasthenia gravis, I want you to think, I'm tired. I am tired. Okay, so acetylcholine is a neurotransmitter that makes the muscle move. So myasthenia gravis, they lack acetylcholine. So it causes weakness and fatigue. Okay, myasthenia gravis, I'm tired, weakness and fatigue. Also, it can lead to difficulty breathing, respiratory paralysis, and failure. So I want you to know the test to diagnose this is called the tensilon test or hydrophonium test. Memorize that and make sure you have the antidote on hand, which is atropine. So during the test, if they get the hydrophonium and they get better, like, okay, during the diagnosis test, if they receive the hydrophonium and their symptoms improve, that is a positive diagnosis. They have myasthenia gravis. However, if they get worse, you have to give them the antidote, which is atropine. What do you need to memorize? Myasthenia gravis. I'm tired. The symptoms are weakness and fatigue. It can lead to respiratory paralysis and failure. The test to diagnose it is called the tensilon test. They are given hydrophonium. If their symptoms improve once they get the medication, they have the disease. They have myasthenia gravis. If their symptoms get worse and they start to crash, you have to give them an antidote which is called atropine. The two medications that I want you to memorize for myasthenia gravis are neostigmine and pyridostigmine, which is called Mestinon. How can you remember that they are for myasthenia gravis? Well, we usually call myasthenia gravis, hold on, we usually call it MG, right? Well, guess what? MG, MG. It's just backwards. Okay, so that's how I remember that those are the myasthenia gravis meds. They have the MG in it. It's just backwards. Okay, so myasthenia gravis, I'm tired. Because of they lack acetylcholine, they're very tired and very weak. The test to diagnose it is called the tensilon test. They get the hydrophonium. If their symptoms improve, they have the disease or the disorder. If they start to crash, we give them the antidote atropine. Medications, neostigmine, pyridostigmine. Okay? And I know we're zooming through, um, but these are things that you have to know and you can review in the recording. Guillain-Barré syndrome. It is an infection that destroys the myelin sheath, which is the covering around the neurons of the nervous system. It usually starts after an upper respiratory infection or gastroenteritis. Memorize that. Memorize it. Memorize that definition. You have to know that because they're going to say a patient presents to the emergency room. They had an upper respiratory infection 2 weeks ago and now they have paralysis moving up their legs. That is Guillain-Barré. You have to memorize that definition. The assessment, they have a symmetrical muscle weakness that moves up the legs. It can go up to the lungs and cause respiratory failure where their lungs muscles cannot function. Okay? Interventions, you monitor their respiratory status and you give them respiratory support, oxygen, intubation, mechanical ventilation. The treatment is IVIG, intravenous immune globulin. This will give the person antibodies that will help them fight that infection. Guillain-Barré is an infection. It starts after they had an upper respiratory infection or gastroenteritis. It is a symmetrical muscle weakness that moves up the legs. How can you remember that? This is how. This is how I remember it. Guillain-Barré is a muscle weakness and the U means up and then the two L's are for the two legs. So it moves up symmetrically up both legs. Okay? And it can lead to respiratory failure. So respiratory. So number one priority with Guillain-Barré is to monitor respiratory status. All right? And I know we're zooming through, guys. Don't be mad. But I just want to really finish neuro so that we can stay on track. Next up is amyotrophic lateral sclerosis. This is also known as Lou Gehrig's disease. It is a muscle weakness and it eventually leads to respiratory issues, pneumonia, and death. So again, so this is another situation where muscle weakness is going to move up and eventually that weakness gets to the lungs and then the patient gets pneumonia and respiratory failure. So your number one priority with ALS is respiratory status. Okay. Next up is meningitis. Is an inflammation of the brain and spinal cord. It can be bacterial, it can be viral. Assessment, they're going to do lumbar puncture and they're going to see that the cerebrospinal fluid is cloudy with high white blood cells. Photophobia, their eyes hurt when they see the light. Decreased level of consciousness. Nuchal rigidity, which means their neck will be very rigid. Kernick sign. When you bend their knee, it hurts. Brudinsky sign, when they bend their neck, it hurts. K, Kernig knee. B, Brudinsky, bend their neck. Interventions, put them on contact and droplet precautions. Pain management, and we're going to treat the infection. So these are very straightforward, and you just have to take the time to review them. I really recommend that you review the recording. So we just have a few more to go through, okay? And I know that, but remember I told you Module 4 is very brutal. It's a lot, and it's going to require a lot of you. Read your chapter, review this recording. That is how you're going to succeed in understanding these diseases. Okay, so 2 more conditions, and then we're going to talk about halo and then mannitol. So hold on. Okay, next up is Bell's palsy. Bell's palsy occurs from infection, trauma, or a lesion or tumor on cranial nerve 7, the facial nerve. So it leads to one side of the face being paralyzed. And they can't taste on that side. They can't close that eye on that side. They can't raise their eyebrow on that side. They can't smile on that side. They cannot puff out their cheeks. So interventions as a nurse, we want to protect the eyes from dryness. So if they can't close that eye, we're going to do eye drops, and at night we tape it shut. Oral care, and teach the patient to chew on the unaffected side. Bell's palsy usually will resolve on its own. Okay? So there's the difference. Trigeminal neuralgia was pain, right? Bell's palsy is a paralysis. Neuralgia, trigeminal neuralgia was a pain on one side of the face, like by the cheek area. Bell's palsy is a paralysis. Do you see the difference? Tell me in the chat. Tell me in the chat if you see if you understand the difference between trigeminal neuralgia and Bell's palsy. Can you guys hear me? Can everybody? Okay, all right. So, exactly, very good. So trigeminal neuralgia is cranial nerve 5, Bell's palsy is cranial nerve 7. Trigeminal neuralgia is a severe pain, Bell's palsy is a paralysis. And for both of them, you want them to chew on the unaffected side. Very good. Okay, last disorder we're going to learn about is autonomic dysreflexia. So autonomic dysreflexia, basically, this is a neurological emergency. This is in somebody who's paralyzed, usually from the waist down. What is the problem? Their bladder is full, but they can't feel it, and something is blocking their bladder from emptying. For example, if they have a Foley catheter and The tube of the catheter is like under their thigh or it's twisted somewhere. So the urine cannot leave their bladder and their bladder keeps getting more and more full. This can lead to high blood pressure, which can lead to stroke. Autonomic dysreflexia. This person is paralyzed, usually from the waist down. Their bladder is too full. Something is blocking the urine from leaving their bladder. For example, they have a Foley and the tube of the Foley is stuck under their thigh or twisted. The urine cannot leave the bladder. The bladder keeps getting full, full, full. It leads to high blood pressure, which can lead to stroke. Your nursing priorities. Number one, raise the head of the bed all the way. Sit them upright. Notify the healthcare provider. If they have a Foley, make sure that there's no kinks or twists in the tubing. Okay? And you give them medication to bring their blood pressure down. Memorize those things. You are good. You sit them upright. Call the healthcare provider. Check for any twists or kinks in the Foley tubing. Give them blood pressure medication. This isn't a disorder, it's a device. It's called halo traction. We will learn about this when we get to module 7, which is musculoskeletal. Okay? Medications. The one that I want you to focus on is mannitol on page 132. Mannitol, is a diuretic that is used to reduce swelling and pressure inside the eye and around the brain. So when somebody has increased ICP, we give them mannitol. Mannitol will produce more urine. Okay, so mannitol will decrease ICP by removing excess fluid from around the brain and causing you to pee it out. That is the medication that I want you to know about. Okay, so we're still not done with module 4, but let's give ourselves a round of applause because we finished adult neuro. So you have a lot of studying to do. I really, really recommend that you make sure you have read adult neuro in your study guide, that you review this recording. I'm going to put it up for you as soon as it's done. Review the recording and review your notes. Add on to your notes if you need to. And then with your own Q banks to do some questions for adult neuro. Okay? So remember, module 4 is a lot, but we'll get through it. So this is kind of the pace that we're going to be moving at from now on because med-surg is a lot. It's very complicated, but we'll get through it. And as you study on your own and build on what you're learning here, you will become stronger. And we're still going to do lots of questions in class together. Okay? So, you guys are doing awesome. Don't give up. Hold your head up high. I believe in the name of Jesus, you will pass the NCLEX and you will become a licensed, registered nurse. God bless you all. Have a wonderful week, and I will see you next week. I know next week is Labor Day, but we're going to have class, and if you miss it, it's okay because it will be recorded. Thank you so much. Have a blessed day, everyone. Bye-bye.